All right, welcome everybody. This is our first speaker series event that we've had in a long time, and we're excited to welcome George Huntley, who's going to talk to us about the PBM problem, and he's going to tell us what that is. It's a roadblock to care, and it has to do with insurance in the United States. Here's our disclaimer, which I'll go through really fast. The Loop app is an open source closed loop algorithm to help automate insulin delivery. It is experimental and not approved by the FDA. Patches or customizations are even more experimental. This presentation is provided to assist you in making your own decisions. Today, they're about insurance. In consultation with your healthcare professionals regarding your own diabetes self-management. You take full responsibility for building, using, and running the system, and do so at your own risk. All right, our friend George is a founding member of the Diabetes Leadership Council and currently serves as CEO of both the Diabetes Leadership Council and its affiliate, the Diabetes Patient Advocacy Coalition. He has been living with type 1 diabetes since 1983 and has 3 other family members also living with T1D. A passionate advocate for people with diabetes, George is a past national chair of the board of the American Diabetes Association and currently serves as treasurer of Children with Diabetes. A former CPA, George spent his business career as CFO of Theoris Group, United Pentek Incorporated, and MicroProse Games Incorporated. In his corporate roles, he was the plan administrator of self-insured employer-based health plans for more than 25 years. He learned firsthand the impact of chronic disease management on his company's bottom line and the importance of strategic health plan design decisions to manage cost, reduce overall risk, and improve health outcomes. George is also a highly rated and frequent speaker on the topic of health plan design and drug pricing. And I've had the pleasure of meeting George in person and hearing him give several talks about, about these topics. And those events have been at Children with Diabetes Friends for Life conferences. There is one of those coming up in Orlando in July, and Loop and Learn will be hosting another Loop meetup as we usually do for Loop and all the open source algorithms. With that, I'm going to turn it over to George.
Well, thank you, Tina. Thanks, everybody. And I will try to share my screen here. And the only thing you missed in there is George is a legend in his own mind, building me up quite that way. It's a little scary. But
passionate speaker.
I thank you very much for the opportunity and the invitation to present today. And I do hope I would love for this to be interactive. So if you have questions, if something I say doesn't make sense, just interrupt me. Everybody else does. So why shouldn't you? We will, answer questions. If there's a chat, I think in there, and I will lean on Tina or someone to monitor that in case I can't see. Sometimes when you're running the slides, it's hard to sometimes see. But we are going to talk about our friendly neighborhood PBMs and roadblocks to care. And why don't we dive in? So she did a very nice job of talking about Diabetes Leadership Council and the Diabetes Patient Advocacy Coalition. We are 100% focused on advocacy on behalf of patients living with diabetes. Anything that a patient needs, accessibility, affordability, equity, health equity is a big tenet of ours. The Diabetes Leadership Council is a 501c3. It's the policy shop where we do the research and the education. Everybody on the DLC board is a past leader of a national diabetes organization like the ADA, ADCES, the nutritionists and dietitians, etc. DPAC is the grassroots army. It is a 501c4, and not to nerd out on that, but the difference is the C4 can lobby. And when all you do is advocacy, we are in front of people at the state houses, at Congress, and regulatory, whatever it might be. We advocate at the federal, the state level, CMS, departments of health at the state level, Medicaid, Medicare, all of the above. And we also educate employers on their health plan design because of my background as an employer. driving our own health plan. I know what the employers have been told and what they haven't been told. And an employer is just trying to run their business. Health plans are not their core business. Making widgets, providing the service, et cetera, is. So that's a little bit about who DLC and DPAC are, and why we're together, and why it's very useful to have a C3 policy shop and a C4 grassroots army. DPAC has over 50,000 advocates, all 50 states. So when we get involved in something to try to make change happen, we can send it out and get to and have a pretty strong reach. So giving this live, which this is not, but I'm going to ask you to think about, understanding your story. And of anybody, back to the roadblocks to care. And I'm gonna guess that you're gonna resonate with a lot of this list, unfortunately. Have you ever been surprised with a high out-of-pocket cost for a prescription? Have you ever left a prescription at the pharmacy counter because you couldn't afford it? I hope not, but you might know somebody who's had that situation. I know many people have had that situation. That's not right. Have you had difficulty obtaining your medication due to health insurance? You couldn't get it, something in the way. I'm fully insured, I can't get what I need. Dealt with medication costs changing 1 month to the next. You don't know what you're really going to pay. Had your prescription changed to a different brand without really your knowledge. We call that non-medical switching. We're going to talk about that. Have you ever gone without insulin or rationed it? And I do hope not too many people raise their hand on that. I fortunately have not, but I know many people who have. And I hope the more you talk to people in this community, the more you run across people who have, I know someone who's had that situation. And it is, no one with type 1 should have to do that. But it's happened too many times. These are all roadblocks to care set up by the system that is fatally flawed. So we're going to talk about these roadblocks to care, prior authorizations, and we're going to get into detail on each one. So this is kind of a summary. Prior authorizations, the drug formularies that choose one or the other, out-of-network pharmacies where you're going to the wrong pharmacy and now you can't buy it there. We're going to talk a bit about rebates, and which is where the math on the PBMs really come into play. We're going to talk about copay accumulator adjustment programs. If you're still awake when I get to this point, well done. You've had enough coffee, but it gets wonky. But if you've understood the first four, we can get an appreciation for the evil that is in copay accumulator programs. And then non-medical switching is going to come up, but it's also going to come up in the formulary. So we might touch on that a couple of times. But those are the roadblocks we're going to in general talk. And I, talk about diabetes advocacy all the time. So if you have another question that's not up here, I'm happy to talk about that too. But these are the roadblocks to care that I was planning to spend most of the time on. So I'm going to start with the drug system in the US and where the pharmacy benefit manager sits in there. We very lovingly call this the hairball slide. And I've seen worse versions of this. This is actually simplified. But this is the journey. So we're the consumer. So we're at the top, as we should be. We're number one. We're at the top. And where does our money flow, right? So we start by joining Sam's Club. We pay an insurance premium to join the club, right? And that premium is typically coming out of your paycheck, if you're getting it through your employment, or you may have gone to the exchanges and purchased it on the exchanges, or if you're in Medicare, it's coming, some part of it's free, or you're paying it through Medicare in some way, shape, or form. But you're paying a premium, which gets you access to the health plan. And access to the health plan means access to the network, which is the doctors and the hospitals. It's Aetna, Cigna, Anthem, Blue Cross Blue Shield, Humana, pick your one. But you've paid a premium to get access to that, including the drugs. In everything but drugs, you're getting the plan discount because you've paid a premium to get in. But when it comes to drugs, you're not, and I'll get deeper into that. But this sack of money that you're sending over there is getting you into the club, and it's not getting you. You're not getting all the club benefits that we think you should have. So that's fine. It's coming out of your paycheck. You've made it. Maybe you're not getting to employment, but you've now, New Year's Eve happens. The ball drops. You've had a lovely party. You wake up January the 1st, you're a little hungover, and you are at CVS, Walgreens, wherever your favorite pharmacy is, where you get your drugs. And now I got to buy my prescriptions. And now you really have a hangover because it's your deductible period. And unless you're Medicaid, where Medicaid tends to be almost free, but Medicare, the drug system works differently. But in normal commercial insurance, which most of my comments will be about, you're paying the full price of the drug January 1. So if you've got a $3,000 deductible and you need to pick up, back in the day, 3 or 4 vials of insulin for a month, maybe you've got insulin, maybe SGLT2, maybe you're on a GLP, whatever it might be, you're paying the full amount, and by the way, list price, at the pharmacy counter. And you don't walk away from that pharmacy counter, as you well know, unless you've paid. So you can't finance it. CVS doesn't have a financing piece. You can put on your credit card, but that's what you've wound up. You've paid to play. You've paid to get your access to your medications. But again, you've paid list price. The pharmacy has purchased the drug at a wholesale price, close to list. The wholesaler makes a few bucks, and the wholesalers purchased it from the drug company. So the money they've purchased it. The drug company has effectively gotten list price, and you've given them list price. The drug company then sends this green line over to the pharmacy benefit manager. That green line is called a rebate, and that is on average 50% of the cost of the drug. In insulin, which I'll show you in a moment, it's been 75 to 80% of the cost of the drug was rebate, AKA kickback. So they are sending money back to the PBM because they wanted to get their drug on the formulary. Because if it's not on the formulary, your health plan doesn't cover it and you're not buying that drug. So they negotiate a rebate from the drug manufacturers. And by the way, this is also true with sensors, anything going through the pharmacy benefit. So your Dexcoms are the same, if you're using Dexcoms as an example, not to pick on them. So half of this money. So if you paid $1,000 up here to get access to your drugs, $500 went to the PBM. Now this is January, okay? You're in your deductible period. Why did the PBM get any of your money? Now the PBM is going to hang on to a piece of this, and they're going to send the balance, this green line, going back up to the health insurance company and the health plan. Now, in a self-insured, if you're getting it through your employer, okay, that could be going back to your company if they're self-insured. If they're fully insured or you bought it through the exchanges, it's going back to that insurance company. And a lot of the insurance companies, they're getting about 85, 90+% of the $500 that just moved out here. So $500 came to the PBM. The PBM is going to keep roughly 50. It is not transparent. This is opaque as heck, and you have to get legislation to force them to report it. But anecdotally and beyond, and there have been some states that have required transparency and reporting. So the state of Texas, I know the PBM is kept in the 8 to 13% range, which is why I use 10, because it's just easy math to keep. So they're keeping about $50 of that 500 that you've spent, and 450 went back up to your health plan. Now I will restate my opening comment. The ball dropped. It's New Year's Day. You're in your deductible period. Why in heaven's name did 450 of your dollars land at your company? It's insane. The company is going to say, we're keeping that $450 so we can keep everybody's premiums down. Well, why should the sick subsidize the healthy? But that's what's happening with the rebate system in the United States. Now, once you've met your deductible, and I'm hanging on this slide for a bit, once you've met your deductible, you're not paying $1,000 there. You're probably paying $50 as a copay. You might be paying a co-insurance, but let's just keep it simple for the sake of this. You're paying $50, and the health plan's paying the $950 to get to the $1,000, and then the rebate works. Then the rebate goes back through. They've paid $950. The drug company sends the $500. They've effectively paid $450 net, which is what they should have paid. After the deductible, that rebate is kept to keep all the costs down, and it's, they take the amount of overall cost of the health plan, including the major medical, the hospitals, the surgeries, the doctors, the labs, all of those things. That's most of actually a normal health plan. That's most of the cost. It's typically 80-85%, sometimes more of a health plan cost. They're using those rebates to keep that overall cost down. But while you're in your deductible and you're paying list price, there's no rational reason why they're doing this. But that is why you can't afford that. That is a big piece of why people can't afford meds who are fully insured. We call that underinsured, because you're insured, but you still can't afford what you need. I'm going to pause here for a second to see if anybody has a question on this other than what the hell.
Yeah, George, I have a question. How did this happen? Who?
Oh, you are beautiful. I love this question. You want to, this is Medicare Part D sparked this off, and some really good politicizing. So PBMs have been around for decades. Okay, PBM's job is to process drug claims because it's different than a doctor in a hospital claimed. So it's made sense for an insurance company to outsource the processing of drug claims. PBMs have been around a while. PBMs then got to the point of managing a formulary. Very natural thing for them to do. Medicare Part D comes along. And this is 2003 that it was passed, but it didn't go into law as far as functioning until 2006. Within that Medicare Part D law, they wrote in that Congress, the federal government, shall not negotiate with drug companies directly. They tied their own hands in the law. So you've heard all about the Affordable Care, the Inflation Reduction Act, where they finally said the federal government is going to negotiate directly with the drug companies. And you ask yourself, why the heck did it take them that long to do it? Because they, in 2003, signed a law forbidding themselves from doing it. Absolutely nuts. When they did so, they said, we must use a PBM. Guess whose lobby was involved in writing that law in 2003? I'll give you about 2 seconds to think about which lobby was involved in that. It's the ones on the left-hand side of the screen. And it specifically said that this rebate passed through back up to the health plan is exempt from the RICO Act, which means it's not a kickback. So in that law, they put PBMs right smack in the middle of it, and they said the rebate game is legal. Once that happened, you'll see it. I've got a chart in a second. They figured out how to play the game exceptionally well. How did we get here? The road to hell is paved with good intentions. The good intention of Part D, Part D is a wonderful thing, because prior to that law, seniors did not have drug coverage, and drugs were starting to get expensive even without rebates at that point in time. Seniors couldn't afford their medications in 2003, 4, and 5 anyway. The other thing they did, interestingly enough, and it's not really a type 1 discussion, but they also said no money out of Part D can be spent on weight loss drugs, because there were none at the time. There were none approved by the FDA. That what was on the market then was fen-phen. It was effectively speed, and it was giving people heart attacks. So it was in the news, and the senators, they like to wax eloquent from the podium, and they wrote into the law, we can't have any weight loss medications in Part D, which now is a problem. However you feel about GLP-1s, we now actually have an effective, safe treatment for obesity, and we can't use it because they tied their hands. So we're working on that, and we got to work on the price of it too. But all those things happened because of that. Does that answer your question?
You have a question? Yeah. And then you have another question in chat. It's from Mara. Does the same thing happen with prescription plans that are a percentage of drug costs and not copay?
Yes, it does. So very good question, Mara. Because we call that co-insurance. So you either have a copay or a co-insurance. Both of those kick in after you've met your deductible. So when you're in your deductible period, you're still paying full list price. And after the deductible happens, you're now paying a co-share. Now, it could be even worse in your co-share or co-insurance, that percentage, because the question is percentage of what? Most of the time, you're now paying 20 or 30% of list. So here's your $1,000 that you've purchased. You owe 25%. So you had to pay $250. We now know the drug actually only costs net $500. You haven't paid a 25% copay. You've paid co-share. You've paid a 50% co-share. You just don't know it. So when we actually lobby and try to get laws passed, we've got laws passed in a few states to get this fixed. But that's why we do it. Anytime the patient's cost is based on the price of the drug, it needs to be the net price that the plan has negotiated. You should get value for your access fee to Sam's Club.
I had a question. Well, one point and one question. One point, I know when I was in commercial insurance, they allowed certain drugs to be on a preventative list, and therefore I still had a hefty copay for my insulin or my co-insurance, but I didn't have to do the full deductible on it.
That's an excellent. Yes, you are correct. So some drugs can be put on a preventive drug list. Some are required to be put on the preventive drug list. So a preventive drug list is recommended by the USPSTF, the United States Preventative Service Task Force, which was put in place by the Affordable Care Act. It was actually there. It existed, but it got put on the map by that legislation. That legislation also, it was about the time that high deductible health plans came in, Jim, and those high deductible health plans required drugs to be part of the deductible. And there were many cases where that was a dumb idea, insulin being one of those cases, but they did not put insulin on the preventative care list. So if it's on that list, the plan can have you go right to copay and right to co-share, and you are not exposed to the $1,000. Unfortunately, that's a small fraction of the total drugs on the formulary, but there are in fact a few. And we advocate to health plans, for the love of all that's holy, please put insulin on that list. USPSTF did not.
Okay.
Because they truly look at, if I take this, I prevent a drug and it prevent a disease. And the reality is insulin prevents death. And they need to work on that. But you're quite right. And so when you're looking at your health plan or deciding what health plan to choose, if you are lucky enough to have options, understanding what's on that preventive drug list could be a big deal in your decision process. Because if your most expensive drug bypasses the deductible, that's a pretty big win.
Right. And I guess my question is what is always, I've spent a lot of time kind of studying this to a degree, nothing like this is very helpful. I just don't get what appears to be a bribe, the bribing of the formulary game. I don't understand how that's legal.
Yeah, unfortunately, it shouldn't be legal, but it works. And so I'm going to show you a chart in a second, but the spoiler alert, these guys, PBMs, they do an exceptional job at lowering the cost of drugs. Unfortunately, they're lowering the cost of drugs for their client, which is the health plan and the insurance company. They're not lowering it for you. So it's a very effective tactic because it's an all or nothing. So we get into this medical switching, and again, we're going to, when we get to these slides, but this slide is the best for really understanding it, because you can see these guys are holding the key to the formulary to see which drug, which of these vials you're allowed to have, and they will go to insulin manufacturer 1 and insulin manufacturer 2. And they will say, what's your bid? And whoever won the bid wins the business, and the other is off a formulary. And that's how you have your insulin changed, or whatever drug you're on, how you have that changed. They'll negotiate that once or twice a year.
And that keeps the list price up as well, as I understand.
Exactly.
Yeah.
Yeah, exactly. I want to let me keep talking about this. The next 2 slides are going to be also informative. The PBMs, and these are the OptumRx, CVS Caremark, and Express Scripts. These 3 are the big boys. They have 80% of the U.S. drug market. There are 3 additional ones. Don't ask me to name them off the top of my head. I can't. There are 3 others that'll get you to 90+% of the U.S. drug market, nearly 95. And there are probably a couple of dozen. There are dozens of PBMs in the market, but 3 of them, these 3 own it. And these 3 are owned by insurance companies. So United Healthcare owns OptumRx, wholly owned subsidiary. Aetna owns CVS Caremark. I think actually CVS Health is the parent company, but it's all the corporate family. Cigna and Express Scripts, all part of the corporate family. So how much of this money goes back up to the health plan is less meaningful when these 2 entities are part of the same family. Whether they're keeping all of it or none of it, it doesn't matter, because the shareholder owns up here.
How does that start to be antitrust or something illegal?
You know, antitrust gets involved if any one of them had a monopoly on the market in any of these lines. So they have an insurer, a PBM, specialty pharmacy, provider services, and I could be more intricate with this, but this is an easy graphic to grasp here. The problem that you get to is in any of these lines, CVS clearly has competition with Walgreens and Rite Aid and the others, et cetera. United Healthcare has plenty of competition. None of them are that big, but man, being this vertical allows a choking point in there, and it allows patient choice to get thrown out. And this rebate game, the thing, OptumRx, and I don't have the 23 numbers, 24 hasn't been published yet. But OptumRx made $24 billion with a B in profit per their disclosures in 2021. That was over half of all of United Healthcare's profit. So over half of their corporate profit came from OptumRx, the pharmacy benefit manager subsidiary. United Healthcare is in the healthcare business. They do major medical hospitalizations. 85% of the cost of a health plan are hospitalizations and surgeries and all of that, the complications of diabetes and cancers and all of that. 15% of the cost of a health plan should not be driving 50% of their profit. There's something grossly wrong here. And that is another flag for what's going on here. So it's important to point this out as to, how incestuous it is. And when we get into, they're going to want to make you go to CVS. Gee, I wonder whose insurance plan is likely going to do that. And yeah. So it's just math, and it's for-profit corporate playing. They're not there for you. They are there for them, and they are there for their shareholders up here. And specifically the pharmacy benefit manager, because it is a whole, it's a subsidiary corporation. They do not have any fiduciary responsibility to the patient. The insurance company actually does. They have got some fiduciary responsibility to the patient. They're taking some of your money, and they have to treat you appropriately. But that's part of this game.
That's a good question, and I think I may be jumping ahead of your presentation.
No, it's okay.
But in the news last week, 39 states attorney generals have filed against this ownership ability. What do you think is going to happen with that, or are you going to get to that later? Am I jumping ahead?
Oh, well, we can talk about here. So you're saying the pharmacy benefit managers, 39 states have said we don't want the pharmacy benefit managers to own a pharmacy.
Right.
Okay, and that is it's a big deal. It's a big problem. So let's talk about that. And I'm going to out of network. So I'm going to stay on this while we have that chat. I mean, we can go back and forth because the scenario is they're blocking out other pharmacies from competition. The problem that it creates, one, is it's darned inconvenient for you because the patient, I shouldn't have to drive across town to get my drugs. Nor should I have to change my pharmacist, who I may have a trusted relationship with, to engage in this. But what's worse, and the worst thing that's happening, which is why the attorney generals did that lawsuit, is they are getting to the point where they are blocking competition and putting pharmacies out of business. Now, CVS is not going to put Walgreens out of business, but they sure as heck are putting all the community pharmacies out of business. Now I'm going to go back up to the top here and back to my hairball and focus on this yellow line from the pharmacy benefit manager to the pharmacy. Okay. Because what they're doing is this pharmacy, by the way, has purchased the drug from a wholesaler. They have paid average wholesale price for the drug. When they bought that drug and put it on the shelf at your pharmacy, they had no earthly idea that you were going in there and that you were covered by Anthem or Aetna. They're stocking it because they know they have customers that are coming in. So you come in, you get your drug, and they pull it off the shelf. Well, they've already paid for that at average wholesale price. That's a published number. Everybody knows what that number is, or it's easy to find. The PBM is going to reimburse them a different amount depending upon which pharmacy is. And what PBMs have been doing, one, they've been saying you can't go there, so I'm not going to even pay for it. If they are paying for it, they'll say, well, if you didn't go to the in-network, I'm only going to pay them 80% of average wholesale price. So they now are taking a loss by selling you that drug. And and that is what's shutting down the community pharmacies, and specifically in rural areas. The pharmacy deserts in the United States are scary. It's a very big deal. And fortunately, some state legislatures are looking at it. The pharmacists associations are screaming about it, because you cannot make up that loss in the sale of a drug. And literally, they are selling drugs for a loss. You can't make that up in Hallmark card sales. And that's really what's happened. So a lot of state legislatures are looking at leveling the playing field, and basically specifically putting into legislation, PBMs are not allowed to pay a different reimbursement rate for their own pharmacies as to another pharmacy. And in the scenario that you're describing, they're saying you can't own a pharmacy. I agree with that, because it's just bad. We got to break up the corporate family. Whether that gets legs or not, I can't speak to. We would certainly, as advocates, support that. But what we are supporting is a level playing field, because it's very important that community pharmacies, especially in rural areas, are protected. So where have I danced to? I'm going to take us to rebates, because that's my favorite topic and I can't help myself. Doggone it. Is it not in here? Oh, you're killing me, Smalls. All right. Before we're done, I'm going to find that slide and I'm going to put it up here. I thought it was in this deck, and forgive me, it's not. So let's get into some of the other things that the PBM is doing. Prior authorizations. We've all had prior authorization. Anybody not know what a prior authorization is? Unfortunately, everybody does. It's way out of control. It's way out of control. It's every drug that you want is prior. It's just playbook number one to slow down the insurance company paying money. The PBM's administering it, but it's just the playbook to slow down their funding of any healthcare costs. And it's delaying your care, patient care. They've used artificial intelligence to do it really quick. I believe it was Cigna got busted for denying like 300,000 claims in 3 minutes. That may be a slight exaggeration, but only slight. You can tell somebody laid eyes on that. It's crazy. Physician offices, number one piece of burnout in a physician office are the paperwork for prior auth. Yeah, Tina.
Is the reason for that because people give up?
Yeah. Every time you get denied, a roadblock gets put up, a percentage of people give up. And so if 5% give up, they've just saved 5%. That's big money. And by the time you get to the second time, another 5. Yeah.
I just got one of those where I didn't notice, I sent through my renewal, and why haven't my Dexcom showed up? Well, then the letter comes in, you need prior authorization every single year, and sometimes more than once a year.
It's crazy. So, I mean, that is one of those where one of the things we advocate for, we haven't won on this, but this is a reasonable answer. Look, I get that you have to lay eyes on the prescription and you want to make sure that it's not crazy and that it's an appropriate for treatment for you. I went to a doctor that's in your network. So if you think my doctor's that bad, why'd you let that person in the network? But to redo that prior auth every year is criminal. Now, to make it worse, they are having in many cases, many drugs They have you redo a prior authorization simply to change dose. So when a dose is changed, they'll make your doc. It is the #1 cause of physician burnout. All of this paperwork, they're not spending time with you, the patient. They're spending time on the computer. They've got back office staff that are costing them a lot of money. So this is a level of evil that is getting out of control. So we obviously work against that. Your pharmacy benefit manager is to blame. Yes, George.
George, a question. There's a doctor named Milton, I think Packer, who used to work for MedPage. He wrote beautifully, and he had written that these companies hire retiring physicians who are given bonuses for the percentage of denials they give. So they're incentivized to, at first cut, say no. And I don't know how true that is, but I would believe it. What do you know about that?
I don't know how true that is, but I absolutely believe it.
Okay.
Yeah, somebody's getting an incentive, so I don't doubt that. I don't doubt that for a second.
Yeah.
Our neighbor
Yeah, I
is
think. No, go ahead.
our neighbor is a gastroenterology nurse at Duke, and she's been there for over 30 years. She spends a lot of her time, and I think I might have told you this, George, but she spends a lot of her time calling about these things, and she'll have to call. 3 is the magic number of how many times she has to call for the same thing.
Yeah, it's 3 times to get through. And again, people give up. They get to stage 2 and they give up. They get to stage 3 and they shoot, stage 2 didn't work. They give up. That's why they do it. There is money in the denial. Yes, they're paying somebody to deny it, but there is money in the denial, and they make a lot of money doing it. Very tangential to this issue is step therapy. Yeah, Joanne, I see it's like you had a question.
Okay, I got an email today from a company called ProPublica that has a product called a claim file helper. So it says, find out why your health insurance denied your claim. And somewhere in there, it says they use AI to answer the AI answers that you get. Are you starting to see companies that are popping up who will probably charge you to do?
Oh, I'm sure there's a fee. I hope it's not egregious.
Should I go back?
Oh, I lost it again.
Mira, okay.
Yeah, oh, what's going on here? I just
You're going in and out of mute.
I'm sorry, that was my fault. I muted her. Mira, can you unmute?
okay, yeah, sorry, thank you. I had a situation recently where there's a drug not on the formulary, and they absolutely denied it right away. And they kept telling me I had to take all these other drugs that I've tried 5 years before and haven't worked for me, and they just said they denied it. And my response to them was, how do you know what my situation is? And that's what I wrote on the claim form and sent it back to them. And the doctor had to show records of that I had tried it 5 years ago, and then immediately they responded to it and approved it today. But it's a hassle. I've been waiting on the drug for 3 months now, fighting this.
That's exactly what's happening. And Mira, congratulations on winning finally and for staying in that game. And that is an example of step therapy, which is, it's prior auth on steroids. One level of prior auth is, do you have the disease that this drug treats? Should you have this? This level of prior auth is, I need you to go through these 3 cheaper medications before you get the one that your doctor's prescribed. And in Mira's case, and in many people's case, you've already tried and failed on those. This fail first notion it should be illegal. You can understand the logic. I mean, even as a patient advocate, I understand the logic. And when they tell it to a legislator, in order to control costs, someone doesn't just start with this drug. They have to, there are other very effective medications that work for most people, and we want them to do this first. And what they're not telling the legislator, and I have to follow up and say, is, folks, these people have had these chronic conditions, disease for years. I've had diabetes for 42 years. I've tried that years ago. People don't stay on a health plan more than 5 years on average. You don't stay with employer more. So you failed on that in a prior health plan. Even if your employer changed, as an employer, I was the plan administrator of our plan. We changed networks a few times over my career. The new network prior auths everybody and step therapies everybody because they don't have the records. You know when you change it, that all those records don't go with. It should be illegal if you've already gone through it. And if you prove that, there needs to be a speedier process to get to that, answer. And that's unfortunate that we got to go through this kind of a pain to do it. The only other thing I wanted to add into this, because I said, oh, you've got to fail on these cheaper drugs before you get to this drug. That's not always the case, that it's in fact a cheaper drug. Back up to here, this PBM has an incentive to get the biggest pile of green it can get. And that does not translate to the cheaper drug. That translates to the most expensive drug. Everybody knows, I'm going to use brand names here, Novolog and insulin aspart, Humalog and insulin lispro. Are you familiar with those? So insulin lispro is a biosimilar. It's in fact a generic, when normally there is no such thing as a generic, but in this instant truly is, because it is in fact the same drug. Eli Lilly, coming through the same plant. It's the same drug, goes into the same vial. They slap a different label on it. One's called insulin lispro, the other's called Humalog. Same exact thing happening at Novo Nordisk's plant. Same drug going right through the same manufacturing, goes into a vial, slap a different label on it. One is insulin aspart, one is Novolog. Why in the world would they do that? Well, they got a little tired of being called into Congress and sitting up and getting their heads handed to them by the senators for the price of insulin. Now, I'm not saying they're wearing white hats. They're not. Nobody's wearing a white. There is nobody wearing a white hat on this page except for the consumer. So I'm not here to say, oh, they're wearing a white hat. But the reality is, why did they do that? They wanted to be able to sell their brand name drug at a lower price for the consumer who was uninsured or underinsured, like during their deductible period, they just couldn't afford it, so that you could afford to buy it. And no health plan picked it up. No health plan picked it up. So you won't find that drug typically on most health plans. Probably is today, because all the prices of insulin went down after the Medicare pricing, and some things changed in the drug insulin specifically a year ago. But up until then, no. So biosimilars, generics, they're not always on your plan, and they're not always on the lowest tier, drug tier. So we know about drug tiering, and it's not the tears you cry, even though you do when you see the bill. But there's the generic tier, which is the cheapest. Then there's the preferred brand tier. Then there's the out of non-preferred brand tier. And then there's usually specialty over and above that. Specialty is usually a percentage that co-share, but you're looking at, 20, 35, 50, 25% kind of thing. Well, they'll put a generic or a biosimilar on the same tier as the branded drug because they don't want you to take that. Even after, at this point, you don't care. You're paying the same price. You should be paying $15 less in the scenario I just drew up. You should get a little savings for buying the biosimilar, but they make more green when you buy the brand, because the brand drug sends a bigger rebate through, and they can play games with the rebate, and that's what they're looking for. So that game is causing problems and is causing scenarios where the low cost drug just isn't even covered. Yeah, Joanne.
How dare they? They're not doctors. They are not my physician. I've heard people, when they take Humalog, get the notice that they no longer get Humalog, but they're offered a statin drug. What
Instead of
do
Humalog?
they have to do that?
I've never heard that. I've heard people. I've had this happen to me. I'm on Humalog and I'm forced to go to Novolog. That happens all the time. But that's if it's within the same class of drug, rapid acting insulin, SGLT2s, with the Jardiances, the Farxigas of the world. Anybody on Jardiance and Farxiga? SG, not that you need to disclose. I am. I was on Jardiance. I got forced to move to Farxiga, and then I switched over to a different plan, and they wouldn't even cover it. I found a drug called Brenzavi, which is the same class, SGLT2. It's $65 for a monthly supply. Farxiga and Jardiance are closer to $400. Health plans don't cover the $65 drug. It's starting to get there because we're raising the level of awareness that you got to cover the low cost stuff. But again, the PBM wants as much green as they can get in order to put it on that formulary. That formulary is exclusive to the health plan. So we've talked formulary, we've talked out of network pharmacy. They own the pharmacies, and we need to make sure that we protect community pharmacies in particular and patient choice. The only other thing I want to touch on this, now that I'm back on this slide, is mail order. They force you to go to their mail order. Oh, it saves money. Horse hockey. What it does is it increases risk. So especially if it's a biologic, like an insulin, if it's something that's injectable. If it's a pill, chances are you're okay, send it in the mail. But if it's a biologic, insulin doesn't do so well in Phoenix in a hot mailbox. Insulin doesn't do so well in your mailbox in Buffalo, New York in February. The supply chain quality control, safety control from the FDA stops at the manufacturer's shipping. When the manufacturer ships it to the wholesaler, that's it. There is no protocol, there is no oversight on the shipment from that wholesaler to that mail order place, and certainly not from the mail order to the consumer. And there's a New York Times article last summer on, and it wasn't insulin, but there was a biologic for, I want to say, a kidney issue, and really, really, really bad health outcomes happened. And the plan forced them to go to buy it through that mail order. Another thing to be aware of. So if you are buying a biologic through mail order, be wary. I don't mean to scare you on that, but it's a reality. And we talked to legislators about that. I talked to employers about that. That one is not the top priority, but it's a problem. It's a problem. We talked about rebates. And I'm going to try to find that chart. We want to eliminate the PBMs. We call it delinking. We want to delink the PBM's revenue from the cost of the drug. It's an inherent conflict of interest. They should get paid a fee for their service. They are in fact providing a service, but it's got to be limited to that. We will win that one eventually. Joanne.
Okay, so these PBMs, I just looked it up. They're publicly traded, so that's CVS or Cigna or United Health Group. they're driven by shareholders and they're driven by profit margins. What
Bingo.
hope is there to push back on this?
Regulation. So they're never going to do the right thing on their own. Okay, so and you know, we're in a capitalist society. In case that's news to anybody, we're in a capitalist society, and our healthcare system is for profit. Now, the rest of the free world, even if they have a capitalist society, they kind of put healthcare on nonprofit. They remove those incentives there, not us. So everything costs more for us. But in our capitalist society, whether it is banking, whether it is drugs and this kind of stuff, regulations get put in when the players on the field don't behave in a fair manner. And they get put in when the citizenry, that's us, are not able to protect and defend themselves. We are defenseless to this. So if Congress or the state legislatures don't step in and protect us, we're going to get taken advantage of, because everybody on this chart page below us is making money, and they're making money off of us. And that there's got to be more regulation on there. And so getting that done, which is basically getting a law passed saying you can't do that anymore. That's what we try to do. And it's going to take, it takes time, and you got to do it all across the country, because half the country is covered by their employers. About 20% are covered by Medicare and Medicaid. You've got another slice covered by state regulated plans, like 15 or 20%. And there's another little slice that's, so if you want to cover everybody, you got to go to multiple different places. And by the time you get to the states, you got 50 of them. It's a lot of work. It's job security, but I really would like to be out of a job.
All right, we are,
You're out of time.
We're right at an hour, and I'm thinking if we can go through your slides without more questions, maybe we can get what you got ready done.
Yeah, I'm gonna stop here. So we've got copay accumulators, non-medical switching we've talked about, and then how to, we're all getting no's. Copay accumulators are where you had to use a manufacturer coupon. You're in your deductible, you got $1,000 drug, you can't afford it, you find a coupon for the manufacturer allows you to pay $100. So you go to the pharmacy and you give them you give them the coupon, and you get the $1,000 drug for $100. You've just bought a $1,000 drug, you should get $1,000 of deductible credit. Your plan gave you zero help on that. A copay accumulator steals that $900 away from you, and you wind up not getting credit for that. The plan effectively gets their deductible paid twice, and ultimately it's a major disincentive for any manufacturer assistance. Why would a manufacturer provide assistance if it's going to be stolen by Aetna? It makes no sense. We sued the federal government over this. We won that lawsuit, but these things still proliferate. So I won't go deeper into that, but those things exist. And then, if you get a no, don't stop. Stay, appeal it, do another prior authorization if that's what you got. If you get a no, appeal. They are counting on you to stop. That's how they make money. Be the squeaky wheel. We have on our website state scorecards if you want to look up your state as to what bills are, what laws have been passed, emergency access to insulin caps on the cost of insulin, making sure that it's in that preventive drug, Jim, to your point, undesignated glucagon. There's many other things that we talk about. But if you're curious as to where your state stands, we keep that up to date. We update it every year at the end of the sessions of the state houses. I urge you to participate in the advocacy arena. If you are not a DPAC champion, please go to our website, diabetespac.org. We'll get you these slides and get them and sign up. Please also go to diabetes.org and sign up to be an advocate with the American Diabetes Association. Please also go to breakthrough-t1d.org and sign up to be an advocate with them. We typically do slightly different things. JDRF, Breakthrough T1D used to be JDRF. They do research only. They do no state work. We do a lot of state work. We're not going to get involved as much in research because they've got it covered. We sign on with them. ADA does certain things, a lot of safe at school work. So sign on to all of them. We're not going to spam you. We're not going to ask you for money. They will, but we're not going to ask you for money. But your voice matters. Without your stories, it takes, and I will shut up, Tina, I promise. But
No
it
rush.
takes 4 players to get a law passed. All right. 1, I need a champion in the legislature who's going to champion this within the chamber. Okay. I need that person. I need somebody who understands the science, especially when we're talking about medicine. Okay. So I need a scientist, a doctor. So I've got the medical side of this proving that this is effective treatment. This is sound policy that we're asking for. 3. I need the economic side of this. I need to be able to tell them what it's going to cost and why this is a good investment. Even if it's going to cost a little bit, you're saving lives, etc. You need the economics or you're not going to get it passed. 4, you need to make sure they understand their constituents care. That's us. That's you. That's your story. And it needs to be as personal as it can be and as local as it can be. I live in Indianapolis. If you're in Virginia, my story in Virginia, I have credibility because I've got a business card and all of that. But if you live in Virginia, say, look, you're my senator and this impacted me or my friend down the street, my daughter, my son, my whatever, that's what they need to hear. And they need to hear all of that in conjunction of it. These advocacy organizations like DPAC, again, like ADA, it's not a competition, it's a community. We will engage you when there's an opportunity. It takes forever to have an overnight success. The Affordable Care Act that got done in 2010, that took 3 decades, multiple failures and tries, et cetera. And suddenly overnight, we finally have Affordable Care Act. It happened. It took forever. But when the lobbying happens and the time and need for your stories happen, that window's really short. I've got to get those stories to a committee that's going to hear it. And I don't even know that committee hearing is going to happen, but for 48 hours in advance, I may know a week in advance, I want you to send this thing, but your story really matters and the timing of your story matters. So I urge you to sign up. Don't worry about the grammar. Don't worry about anything. They work for you. And I urge you to get involved. And even if it's just to send that email with a little bit of in the middle of it, they all offer you an opportunity to personalize it. Take that opportunity. Write 3 sentences. Write more if you can. These are the stories that we talked about when we opened up. These are the stories you should put in that personalization. This is what happened to me. This is why I couldn't afford it. This is my drug kept changing one month to the next. This is I can't stay stable. It's hard enough to live with this disease, much less deal with all the garbage that we have to go through in order to get access to the care. I'm going to stop. I'm not going to go through all of these. If you get into social media, but go to a town hall, get as involved as you're comfortable getting involved with. Your voice does matter. We will communicate with you. We will not spam you, but we will tell you what's going on and urge you to be part of that and would welcome you to be part of that. I know Tina and Joanne and Mary, somebody, Ellen, you're part of this, and we appreciate that very much. Anything else we'll do other programs. I'm going to stop there and just say thank you very much.
Thank you so much, George. I think we could take a couple more questions if people have them. Anybody want to ask? So
I
I put
have
one
one.
in. Oh, go ahead. Go ahead.
Hi, George. Sorry I came in late. I had a problem with the link, and I want to thank Joanne for inviting me. I live in New York State, and our Attorney General has not been involved. I just heard about this the other day. I just joined DPAC. And how do we contact them, and what should we say to our Attorney General in New York as far as the importance of getting involved in this?
I would urge, if you are so moved, just call their office. Okay. Calling their office, say, hi, I'm Lori. I'm a constituent. I see this is going on in other states. This is important to me. I would really appreciate it if your Attorney General would look into this and consider joining into that. It's that simple. Doing the same thing to a member of Congress, doing the same thing to your member of your state legislature, picking up the phone. 7 phone calls is a groundswell.
Yeah.
Their phones don't ring. So don't think your voice matters. You're 1 out of 7 that's needed. If everybody on this phone call called, wow, crap, we got all these calls today.
Well, I happen to live outside of Albany, New York, where they meet. So I go with AARP, but frequently will turn this subject to diabetes. And I'm now advocating more and getting ready to do a little more. Speaking about aging with diabetes and so forth. So yeah.
I'm going to find this slide while we're chatting, and I know we're way the heck over, but aging with diabetes is an issue that, one of the things that is not well understood is what happens when patients age. The only thing I'm as tuned into on it is the notion of, I'm in the wrong place. Forgive me. I'm multitasking, but the notion of as we get older, the time and the tightness of that time and range is less important. We all know why, but in fact, it's more dangerous to go low than to stay high.
Right. I have a lot of information on that. I've been in the Joslin Medalist Research Study for 20 years. I've had diabetes for 70 years, going on 70.
Congratulations, and I'm sorry.
Don't be, I'm fine. It hasn't stopped me from enjoying life. The other thing is I do have contacts with the American Diabetes Association. I have quite a few contacts through Joslin because I went there since I was a child and met Elliot Joslin. So anyway, I'll be in touch, and I'm
Please.
glad I found DPAC and joined the group. I'm looking forward to it.
Awesome. Can I steal this back real quick?
Sure.
I know you're gonna, this is the slide I wanted to share. This is insulin from 2012 to 2021. I have one more year, but this isn't the slide that I found. This is list price, went up 143%. The net cost of insulin got cut more than in half over that same decade. That's what happened with rebates. And this is, if you went back to 2006, when that first started, you can obviously see these two will start meeting as you get down 6 more years. That's when Part D was enacted. So this is the picture's worth 1,000 words. I'm sorry I didn't have that in the other deck, but I will move it over before I send this over to you, Tina. And if you want to send this out to the group, that'd be
all
great.
right. That'd be awesome.
But I wanted you to see that this delta should be going to you. They are saving their customers money. Their customer ain't you.
Yeah.
So hopefully you're all ticked off.
We really appreciate you coming out to talk to us, George. We would love to have you come back and talk with us another time too, George, and I'm sure there'll be a lot of questions. We'll put your slide deck out there. We like to say to our members, if you'd like to support the things that we do, we suggest donating to Night Scout Foundation. Yeah.
So Tina, there's one more question in chat about why DME companies charge so much more for DM supplies compared to pharmacy benefit?
Thank you.
And that's not
Well,
probably not a
but-
short answer, but
Yeah, the answer to that is mixed, because there are some scenarios where it's cheaper and some scenarios where it's not.
Mhm.
Yeah.
So it's not a hard and fast all the time, this is cheaper than that. I could say that in some cases the pharmacy benefit side of it, because of the rebates, could creep it up, because that gamesmanship doesn't play. The only other thing that happens in DME, you tend to not have a preventive. You tend to go right. You're in the deductible. It's rare that bypass. So you may have an experience where you're in a copay versus you had to pay the whole thing because it was under DME. So that could have come into play. Beyond that, it's going to be a sensor by sensor, device by device situation.
For support, a lot of people ask us about support. You can donate to Night Scout all the time. Thank you for being here. Thank you for looping with us. And you can visit us online at all these different places. And that's a wrap.
Thanks.
Thank you all very much.
everybody.
thanks.
Thanks.
Appreciate it. Have a great night.